Welcome back. Today we are performing a surgical release of the A1 pulley for a patient presenting with a classic trigger thumb. We begin by ensuring a sterile field through standard painting and draping of the hand. Next, we identify our landmarks. The incision will be made at the level of the metacarpophalangeal joint crease of the thumb. We then administer a local anesthetic, typically 2% lidocaine, into the subcutaneous tissue at the crease, ensuring the patient remains comfortable yet able to move their thumb during the procedure for intraoperative testing. Once the anesthesia has taken effect, a transverse incision is made directly over the MCP joint crease, centering it over the palpable flexor tendon. Now, using fine artery forceps or tenotomy scissors, we perform a careful blunt dissection. It is critical at this stage to protect the digital neurovascular bundles, which run in close proximity. We continue the dissection through the subcutaneous fat until the glistening, white fibers of the A1 pulley are clearly visualized overlying the flexor pollicis longus tendon. With the A1 pulley identified, we perform a longitudinal incision along the midline of the pulley. We use a scalpel or scissors to divide the pulley proximally and distally. Special care is taken to ensure the incision is perfectly longitudinal to avoid any accidental trauma to the underlying flexor tendon. You will often feel a give or a release as the constricting fibers are divided, allowing the tendon to glide freely. Confirmation of a complete release is the most vital step. We ask the patient to actively flex and extend their thumb. As you can see here, there is now an absolute absence of triggering or catching. To further ensure success, we gently retract or take out the flexor tendon slightly using a small hook. This allows us to inspect the proximal and distal edges of the pulley and tear or release any remaining tethering fibers. This maneuver ensures that the nodule on the tendon can pass through the space without any mechanical resistance. After achieving meticulous hemostasis and providing a thorough saline wash, we proceed to wound closure. We use a horizontal mattress suture technique. This is preferred here as it provides excellent skin edge aversion and ensures a secure closure over a mobile joint. The procedure is now complete, and the patient will start early range of motion exercises postoperatively. I hope this step-by-step walkthrough was helpful for your clinical rotations. Don't forget to review the hand anatomy before your next scrub-in. See you in the next case.